Kia ora tātou, and look, thanks very much. It's great to be here amongst lots of friends and colleagues, and I think it's great that I can just follow on from Sarah, because I think just to be able to briefly introduce SHIVERS-V, and I know that many of you were at the Symposium yesterday, so I don't want to go over it, just to briefly introduce who SHIVERS-V is, and just then to look at how a research project can really work closely with national surveillance to support strategy policy decision along with other research outcomes. So I think this is a lovely example, and thank you for being able to follow on from Sarah, wherever you are. I think this is great. So, you know, what is SHIVERS-V? Well, the first thing I want to say is that the privilege that we've got our funders here with us today. Bit of a challenge getting here, but we're very pleased to have our Flu Lab funders with us today. So thank you very much, Julie and Casey, for joining us, and we're really grateful. Because of our funders here, we're able to present some SHIVERS-V progress today. And what is SHIVERS-V? Well, is it not moving on this one?
Yes, it's not.
Oh, it's only moved on that one. I have to.
Yeah.
Got it. So, I mean, SHIVERS-V is really looking at you know, what's happened since the arrival of COVID. And as Michael pointed out yesterday, it's not post-COVID. It's since the arrival of COVID, the disruption and change in the epidemiology, particularly to flu, but in the respiratory virus space in general and the interactions with flu. So that's the basis from SHIVERS-V. So look, I just, as I showed yesterday, these are the general 6 key objectives. And after listening to Makalani, I just want to say to Makalani, we are working on all 6 key objectives. So some of them faster than others. But anyway, this is the general approach we're taking, and I did present it yesterday. So what I really wanted to focus our conversation on was the surveillance platform. So the concept that we can pull multiple surveillance platforms together to answer important questions. And that is the joy of being in New Zealand and the joy of being with colleagues and friends, that we're in a really great position to pull our multiple surveillance platforms together. So we did touch yesterday on the virology and the genomics, and I know that our colleagues will talk later on today about the genomic surveillance. And, you know, as they have demonstrated to us, when we saw the RSV resurgence in 2021, they were able to track virologically that the origins are likely to come from our dear friends in Australia when we opened the borders to Australia, and not come from some earlier RSV strains that might have been in New Zealand. So that was a very interesting finding, and now they're working on the virological pattern for flu. Now that we've had 2 years of no flu outbreak last year, we're in a really interesting virological position to be able to see the pattern there. So that's the virology. There's been a lot of discussion already about the strength of the SARI platform, and I can't state strongly enough how important and effective the SARI platform has been in counties in central Auckland. It's an amazing tool over time, stable surveillance for all of us, for research and for surveillance. And I really celebrate Sarah's discussion around the potential to keep that platform going, but to look at whether you can do electronic linking for other parts of New Zealand so that you can validate them against the Auckland gold standard. I think that's a very powerful thing to do, and we really want to be part of that. Now, the next one is the whole ILI primary care area. It was very disrupted with the arrival of COVID for a whole lot of reasons. But one of the most interesting ones was that the priority focus was to take samples for COVID. And so the traditional ILI approach, a cough plus fever where you take a swab for a PCR, was no longer pertinent when everybody was requiring a RAT test first up. So there's a couple of different approaches we took. One is an interesting pilot we've taken where our practices, we had sentinel practices that were taking a RAT test and a PCR at the same time. And that is looking very positive. So just a small pragmatic approach to primary care surveillance, to be able to take one swab, which is what they needed to do for their priority business of acute care, at the same time as meeting our needs for surveillance. So I think that was a really interesting example. The other challenge we had was the definition of ILI versus with COVID, they wanted to do a RAT test on anyone with respiratory illness. So we moved towards the broader brush ARI surveillance in primary care, but still collecting samples. So I think there's the question of how we collect samples that fits with the flow of primary care, and whether we stick to the traditional ILI definition or move to a broader ARI definition. So we will continue conversations and work closely with the ESR about what is the best approach going forward, both as to whether it be ILI or ARI, and whether we can do a combined swabbing approach. And then, you know, how many swabs do you need in the country versus surveillance, a syndromic surveillance? And Sarah has already touched on the fact that we work closely with Datacraft. Jaden McRae from Datacraft works with Tony Dowell, who's in the room today, and have been doing so for quite a long time on respiratory disease surveillance. And this is really looking at, I think I said this yesterday, we all know how wonderful general practitioner notes are. We all write beautiful notes. But our amazing IT colleagues are able, through natural language algorithms, to pull out meaning out of the very brief GP electronic notes. So we've got the potential to collect very large data, and we showed you some early data yesterday, looking at influenza-like presentations at primary care, and to get a much bigger, larger picture over time through a different approach. And so we've been working quite closely with Datacraft on that, and we showed you some of the early data yesterday. So challenges there, but also lots of positive ways forward. Now, the final surveillance platform that I really wanted to focus on is we've had a big gap for a long time. We're very good at the traditional surveillance, but we are not so good at listening to the narratives and pulling the narratives into the surveillance. And that's the big gap for us in all our projects, you know. So it's all very well from my end of the world to have the best vaccine in the world, but if the community doesn't want it, what's the point? It's all very well to have great policy decisions, but if none of us choose to wear masks and we don't choose to have social distancing, what's the point? So what we are really lacking in our combination, in our surveillance platforms, is listening to the narratives at all levels, both at the primary care level and particularly importantly at our community levels. And I really celebrate the starting point with Tanifa of really thinking about what the communities are saying, thinking and feeling. And we have a need, and we're starting to move towards setting up platforms that are repeatable over time to listen and feed the narratives into all these amazing platforms. And so we have got some platform available. We have started working with the Well Kiwis cohort to collect community narratives from people who are, you know, over time in the Well Kiwis cohorts, so that we can repeatedly hear their voices and listen to their voices and feed them. And now the Well Kiwis cohort may not be ethnically, geographically, age-wise diverse enough, so we will need to pull some others in. And we've been working with our colleagues in Counties Manukau, Moana Connect and Hapa Te Hauora to be able to build up some other community narratives within the surveillance. So what we are looking towards is a much more 21st century thinking around using surveillance platforms, pulling the data together and thinking in a much more flexible way to answer some of our policy, surveillance, clinical questions that we've got within it. So this is an integrated model that I've used with Professor Tony Dowell for a few years now, the concept of pulling these surveillance together and looking at a much more integrated approach where we recognise a somewhat unpredictable world at the moment, and we can design tailors that are very much listening to local voices with local context, but pulling in all our different multiple data sources. So recognising that this is a different way to think about surveillance and bring it together in a different pattern. And so just for SHIVERS-V, this is where we are at this point in terms of connecting all the different parts to the SHIVERS-V program. So I have to look backwards at this one. So you can see that we're collecting a lot of data and thoughts to answer questions around epidemiological patterns, looking at severity pyramid that Sue often shows, and particularly then following through the changing epidemiology longitudinally over time. You know, we showed everybody a little bit of data yesterday about the quite interesting changing epidemiology between having the absence of flus and its re-arrival. What impact will that have over time on our communities? Then using this, of course, for modelling and for economics as we go forward. So that's the other angle. And alongside this, putting it together with the health sector and community narratives, and then blending that with all the amazing data coming from our basic science. So this is us looking at ways of pulling it all together to answer all the important questions that we have in the SHIVERS program and many of our other colleagues have outside as well. Firstly, I think we're a connected research community with surveillance, and I think this room is evidence of that, and I really think I celebrate Aotearoa New Zealand for that. I think that's really powerful. So using the research community usefully to support policy, to support the Ministry of Health, and to support the New Zealand outcomes, and internationally. The use of our cohort platforms that Sue will discuss more, I think is fantastic, to actually be able to use those platforms to collect and synthesise the narrative data over time. It's standardised, it's repeatable, and it's engaged. And then effectively connecting our multiple databases. We've done quite a bit of that, but there's more we can do. So I think I've touched on that. And then we've got the challenges, which is when we've got siloed surveillance systems, we get siloed views. And so we need to break free of all of our traditional models. And I'm trying very hard to be public health and primary care all in one, Michael, and consider the community at the same time. Because I think this is great that we bring our siloed systems together, and we're doing that really well. And we need to understand much more the strengths of taking a mixed methodology approach. Cohort studies used alone will be limited in diversity, so the importance of making sure we've got the right communities and the community voices, our Māori communities, our Pacifica communities, disability, you know, all the different communities we've got in New Zealand, and geographical reach. And need to keep the research, surveillance and policy communities well connected, which is great today. So that's where I'm going to stop. Thank you very much, Ruth. Kia ora koutou.